as last time. We're just
This meeting is being recorded.
yeah, and we do this for folks that aren't available so that they can watch later. If you don't mind, I'll ask each person just to introduce the next person to do a brief introduction. So with that, maybe I'll go to you first, Naomi.
I'm using Zoom on my phone instead of my laptop, and it's a whole new experience today. My name is Naomi Larson. I'm the Executive Director for the Chetwynd Chamber of Commerce. I'm also the Chair of Community Futures Peace Liard. I've been here in Chetwynd since 2006. We had a 5-year plan, and we're still here in 2022. Can I say the community, nice place, sucked us in. Here we are. Yeah, and I think that's kind of really about it. So I will pass on to, I'll go with the top of my screen, Bridget.
Oh, yeah, that'd be me. Like last meeting I was in, there was 2 Bridgets, so I double check this time. So I'm Bridget Butler. I'm in Smithers in the Wet'suwet'en territory, and working with the RCCbc. I am their innovation technology lead on this project, and I'm a health mathematician. And since Jess and I are kind of a pair, I'll hand over to Jess.
Thanks, Bridget. It's really great to be here. Thanks for having us, Gordon. I see a few friendly faces. Hi, Paul. Hi, Ray. Nice to meet the rest of you. I'm Jess. I live in Kamloops on the traditional territory of the Kamloops-Tishoquimic people. And I'm lucky not only because I get to work with Ray and Paul, but also Bridget. And I work in my capacity as project manager for this righteous rural personal health records project. So happy to be here. And how about I pass it off to Sarah?
Hey everyone, I'm Sarah. I'm in Caslow. I am with BC Rural Centre doing the digital media coordination role and co-hosting with Gord so that he can focus on the topics and I can troubleshoot all the stuff from behind the scenes. It's lovely to be here, and I'm on the traditional territory of the Ktunaxa, Salik, and Sinixt people. Oops, and I will pass it to Mark.
Hi guys, CEO of the Institute for Health System Transformation and Sustainability. So we do 2 things province-wide. We do BC Centre for Palliative Care, trying to advance palliative care across the province. And we're doing a big project related to type 2 diabetes, trying to advance prevention, management, and so on. And I'm joining you from the shared unceded territories of the Coast Salish people here down the lower mainland. Over to Ray.
Thanks, Mark. Hi, everyone. So Ray Markham, a rural GP in the village of Vermont, which is on traditional territory of the Coat-Laitinais and the Sim people, but actually currently on Coast Salish territory in the Big Smoke in Vancouver. Part of the team with the RCC Rural Coordination Centre of BC. And I will hand over to Alex.
Thank you. Good afternoon, everyone. Alex McMillan. I'm with the BC Chamber of Commerce, and thank you very much for the invitation to join you in this group. I am currently situated in Vancouver on the traditional territory of the Musqueam, Squamish, and Tsleil-Waututh people. And yeah, I'll hand it over to Pablita.
Good afternoon, everyone. Can everyone hear me? Sorry. Okay, cool, because I'm actually calling from Victoria, but I'm in the Alliance Française on Island, and so there's a lot going on back in the background. So yeah, Pablita Thomas, ED of the BC Hospice and Palliative Care Association. Live, work, mostly play on Victoria Island, in the territories of the Lekwungen people, and neighbors of the Tiswak and Elma and Mahaki people as well. Thank you.
Sorry, Mike, maybe we can go to you.
Mike, we can go to
you. Mike Wally, Executive Director for the Resource Municipalities Coalition, currently residing in Fort St. John and representing Northern Rockies Regional Municipality, City of Fort St. John, the districts of Taylor, Tumbler Ridge, and Mackenzie. So I'm on Treaty 8 territory. To go through the laundry list would be an extra 5 minutes, but yeah, totally on Treaty 8 territory. And I am lost as to who next is to hand it off. I think there's 1 or 2 names left on that list.
Yeah, Mike, you might not be able to see them all. I think Lisa, please.
Hello, everyone. My name is Lisa Muir. I'm Chief Operating Officer of Pacific Blue Cross. We provide private health benefits for folks all throughout the province. Health, dental, and work or life and disability benefits. And I'm coming to you from the unceded traditional territory of the Coast Salish people here. We are located in Burnaby, British Columbia. It's also part of the Coquitlam Nation. And very interested in learning and discussing more about what we can do from a private benefit sector to help support healthcare needs of people living in rural communities, and what we could do to improve the health and well-being overall.
Yeah, thank you, Lisa. Appreciate it. And finally, Leanne.
Hi, everybody. Good to see you all again. Leanne Prue, Vice President of People and Culture at Kootenay Savings Credit Union. We have 11 branches across the East and West Kootenay region. And I have to admit that we're a little late to the party on the land acknowledgements front, and I commit to have that dialed in for next time.
Yeah, a lot of the Kinbasket tribes and a couple other Simk as well, I believe. Yeah. So with that, thanks very much, everybody, for joining. I really appreciate it. And I'll hand it over to Jess to talk about this project they've been working on.
Thanks, Glenn. I appreciate the opportunity to be here. Engagement's a core tenet of this project, and we've had the luxury of engaging with a whole host of system stakeholders over the course of this project. So I really value the opportunity to be here. Truthfully, haven't had many opportunities to engage with people like you. So I took the liberty of creating a PowerPoint. I'm going to breeze through it because I want to leave ample enough time so that we can have that dialogue and questions and answers, and really looking forward to your feedback and ideas. So let's share my screen here. This one, optimized. Now, can you folks see that?
Yeah.
Okay, great. So I'll preface this by saying I can't see any of you. So if you have any questions, please just feel free to interrupt me. We're going to do a high-level overview of the project, what a personal health record is in contrast to, say, a portal. And I thought it might be interesting to look a little bit closer at how we've approached our engagement in community, and then we'll get to some Q&A. So again, interrupt me, please. I can't see you. Okay, so our Rural Personal Health Records project is grounded in a vision, which is simply put, we see a world, a healthcare system in BC where people and their families and those who care for them are included meaningfully as partners in their care, i.e. the primary care networks, community team-based care, and planning. We've articulated this vision graphically in our petal flower power diagram. I think this was Bridget's brainchild, but anyhow, you can see that front and center is the person and the family and caregiver as protagonists, and subjects, not objects, in the healthcare system as they navigate through and access different levels of care there within. And so our mission is also very clear. We're in the business of supporting full citizen access to the health information, full stop. Not for its own sake, but in order to facilitate that engagement in their healthcare, and to facilitate partnerships in health as well. Operative words: partnership and engagement. So Bridget and I and Ray and anyone else is at the RCCbc hopefully is happy to talk to you ad nauseum about the value proposition of a PHR. Not just for patients and not just for providers, but I want you to consider some of the thoughts from other thought leaders in our system that acknowledge that not only could a PHR benefit patients provided, but the system as a whole, insofar as saying that it's the greatest opportunity we have to improve quality in the system. And if it's true that we want to reach a high level of quality in the system, that a PHR is actually core to that and a prerequisite to that happening. I know we've been talking a lot about personal health records probably for decades now. And so I would argue that the future is now, especially in view of the context that we find ourselves in now. I think I mentioned at the forefront that engagement is a core to this project. I put this slide up not just to brag about all of the people with whom we've engaged and dialogue with, but just to highlight that it is important, and it highlights the opportunity, the importance of this conversation too. And I'm going to keep going. And this is where I'm going to pass it off to Bridget, because she's our in-house resident experts on all things personal health records.
We started talking about our journey from portals to PHRs. So we have a lot of portals in the province. We call it portal soup. There's lots of different ways to access your data. But what we were envisioning, what we were thinking forward was like portal plus, more. A holistic, so all your data in one place, not just all over the place, is integrated. So you're integrated with your care team and your providers. You can share information around from you, not just standing in a corner by yourself, and then it's portable. You can take it with you. Where we are right now with access is we have a lot of those regional, provincial level data in silos. What we envision is the patient would have an independent, full view of all of their records in one place. We're not there yet. We also see the experience right now where we are. Patients can see their data right now. Some of their data is in these systems. We would like to, and we envision that you could interact with that data. So you'd have like a live care plan, for instance, and somebody updates it and then it's updated for you as well. So it's more integrated. And then what we were hoping to see as well is that impact. So right now, you see the data, but now what? Where's the what now piece, so that your care plan, what you do next, and how you can participate in your health and wellness. We have taking a vendor agnostic approach, which means we're shameless and we'll work with anybody that'll work with us. So we're not locking this down to one or two vendors. We're not trying to pick a winner. We're trying to move the needle and showcase the art of the possible. And the other difference about us, rather than a provincial level down project, we're taking a community up. We're building with communities and identifying the needs from the community. Bing.
Operative words: holistic, integrated. Next. Oops. There we go.
And then, so what we've been calling the secret sauce, what we're hoping to see in a personal health record going forward. So these are the things we've been advocating for. So we want like an open standard type approach. So it's not just locked down in one vendor and you can't take it with you or do anything with it. We would like to see all the data sources available, as we had mentioned. We would like to see the integration piece. So not just standing by itself in a portal, but actually integrated with your care team. We would love to see the portability built in. My mother moved to Newfoundland and lost access to all of her records here in British Columbia. And then we really have found, as one of the secret sauces, that the providers also need support in this. You just can't expect them to just do one more thing on top of everything else they're doing. So there needs to be some support for the providers and the care team as well to make sure that you are fully integrated as patients. Thanks, Jess.
Awesome.
Design thinking really focuses on the user experience so that what you are building reflects the needs of the community.
I really appreciated working in Valemount at the Design Lab. I think it was a very powerful experience to hear the stories of the patients, hear the stories of providers, and then have each group hear each other.
And the value for me as an informatician was to be able to sit there and listen to the stories in how the patients described what was happening in their system and what they needed for their care, and then the providers being able to sit and describe what they're seeing in the system and what they need to be able to look after their patients. But when the two groups came together and shared the same common problems and the same solutions together, was very powerful to see those stories knitted back together. And so there was a lot of common ground, and I think it really brought the community closer.
We make so many assumptions that we understand the other person's perspective, and if there's any opportunity to bring that team together to try and make an understanding, I think there's just a lot of misunderstandings that could be avoided.
And design thinking really focuses on the user experience. So the entire process really is on bringing the perspective of those who are going to experience either the service or the product that you're creating. And so around the personal health record project, it was paramount that the voice of the patient, the voice of the community was involved in that design. But it was just as paramount to include the provider perspective, to then lay a foundation to explore what's possible.
There was a lot of common ground that they could bring together between them, and I think it really brought their community closer.
Did you recognize anybody in that video? The reason I included that video was to just point out that we're really championing and role modeling the grassroots sort of bottom-up community development approach, as opposed, in contrast to the here's a solution that thou must adopt and use, knowing that that secondary approach would necessarily fail. So that's what we're trying to do essentially. Cole's notes on the community engagement sort of design thinking approach that we took in Valemount. We did journey map exercises. Don't have time obviously today to go into that, but to underscore that in summary, it was obvious to at the end of it that despite the fact that providers are rightfully in some ways reticent, given just their high workload and other issues, rightfully reticent to, take on a PHR, that generally speaking though, they see the value proposition is a way to make their life easier and ultimately provide better care for their patients as well. And then here's another journey map around the community. We'll go straight to the summary. Long and short of it is that citizens in Valemount, presumably in other communities as well, want to be in the driver's seat, appreciating that if their health information traveled with them, they could better manage their health, of their health and the health of their family. So it was, it validated for us what we thought we already knew to be true, for sure. So working with providers, oh, sorry.
Yeah, Naomi here from Chetwynd.
Awesome.
Just on that note, that's really interesting because I recently had a pretty serious medical incident that occurred, and that information isn't available here. So you can go on your app and get all your information from Northern Health and all your appointments and everything, but the stuff that happened in Vancouver isn't available here, and it's tough to get a hold of. So a lot of people say, oh, you can just find it on your app or whatever, but it's not there because it's in a different health authority. So then it takes a while to make that request, to get all that information sent. It's just not readily available. So yeah, that's an issue as well.
Yeah.
In the north, for sure. Yeah.
And Ray, you could back me up on this, Ray, but it was true for providers and patients alike in Valemount, because it's uniquely situated on the southern border of an artificially drawn health authority border. It's often the case that patients are going outside of their health authority to acquire services, right? So it's not unlikely that I would go to my GP in Valemount, trek off to Kamloops to see a specialist or Kelowna, and then come back to Valemount, and there's that immediate disconnect, right? The information doesn't flow as easily as it could or should. Thank you for that. I wish I could see you.
Yeah.
Anyhow, I'm going to carry on with this presentation. We'll get through it. So it was
One
interesting.
other question. Jess, could I ask one question too? And I'm trying to understand the intent of, because there's so many terms out there, and I'm coming sort of from the private healthcare side of it. The to me, this personal health record, if I were to look at it being a member of the public, I should be able to see anything or anybody I've ever seen. What drugs I'm on, what my test results are, what physicians, what dentist I've gone to, what massage therapist I've gone to, all in one place and readily accessible, so that I can decide whether I'm going to share that with the next healthcare provider to help and make it easier for them to understand what I've been through. How do you leverage, or is your intent to what it looks like a lot of what you've got here, I'm going to say is more information that's under the public sector domain? How do you anticipate leveraging the private sector information? And have you had any thoughts on that front?
I've had lots of thoughts on it. How? That's the big question, right? Truthfully, I don't have an exacting answer for you. That is the dream, though. That's the concept of a holistic, integrated personal health record, right? So at present, and Bridget could talk to you more about this, but at present you can, well, technically, legally, I think you can access any of that information if you're willing enough to drive to your providers and wait in line and have them print out all your records. And if you're going to go to the trouble to do that, you could. But the question is, how can you do it easily? And so that's what we're aiming for. You could go to a health portal and you could see your lab results, or you could access information from another place. I could go visit my allied health worker and then ask for a printed copy, but it's not all, Bridget calls it portal soup. the dream of a PHR is that exactly that, whether you're accessing your services privately or within the system or anywhere else, they would all coalesce and appear meaningfully in one single place. Bridget, did you have anything to add to that?
And just the community up approach. So when we sat with Valemount, the whole community came out, including Allied Health as well. Even the nurse that was working and running in the ambulance back and forth between communities had different needs as well. So we all sat down together to talk about what was low-hanging fruit, what was feasible, what would take a little bit more advocating, what would take a policy change, governance, those kind of things, and started cataloging some of that.
Yeah, I'm just thinking because, again, we've got portals too, every insurer has a portal where, the members can sign on and see the whole spectrum, what drugs have been paid on my behalf, what have I claimed for, what's being paid, what's being denied, what healthcare practitioners have I seen, what services are being done. And I'm wondering if you're building in APIs to be able to extract the data out of the various health authority systems, is there an API that could be shared with the private sector world, where the private sector world can, I'll say, send all the information through to the public, that personal health record world? And I'm making it sound way easier than what I know it would be, because I could have 5 different insurers, therefore I'd have, have to get data from 5 different places, because depending on the type of coverage you have, some insurers, you might have different insurance with different companies. So I'm just trying to think out loud a little bit.
That's the dream.
So you're talking Bridget's language. As soon as you said API, Bridget, would you be so kind and maybe explain a little bit around why we're advocating for an open standards approach to PHR development? Because I think that ties in perfectly.
Yeah, so we don't have that. What we were hoping to avoid was a proprietary approach to every single person connecting in. So with an open standard, that you build it once and it wouldn't matter how the data would come in and out. So we'd be able to share easily and pull data in from out and out as we go. But again, that's our vision. We're not there yet. We start with just provincial data, maybe regional data, and maybe EMR data. If we could just get there, that would be amazing.
Yeah, baby steps.
It's right here. Maybe could I jump in?
You betcha.
Because I think, Lisa, that's a fantastic comment, and exactly why I think we're interested to hear this group's perspectives on that. So I'll maybe kind of throw in a few possibilities that directly answer your question, and then actually maybe suggest, and even there are other kind of value adds for what you're talking about that go beyond that. So a lot of this data will land up in some spot in some way. So first of all, the approach here is vendor agnostic, as Bridget and Jess have said kind of repeatedly, and this idea of open APIs. So the option for sure of giving the APIs to insurers is there, so that they can actually build the plugin. We can't tell private agencies that they have to do it, but we can give them that option. And I think there is actually a value add for them in there, and I'll kind of get on that in a sec. A lot of this stuff, like for instance, if I refer to a massage therapist, I will get it often, like a physiotherapist, massage therapist, or whatever. I'll get a report back, even though they're private. That comes into the EMR. So some of that stuff will kind of filter in. But again, what Bridget and Jess were talking about around that interactive piece, there's nothing to stop the patient from adding that in. I saw this person, and it becomes part of their record, and that could then feed back into the primary care record or the hospital record or whatever. The last piece I would add is there's probably, I imagine that there is a value add for a bidirectionality with organizations like yourself. For instance, you may be able to start offering people, and I know there's a lot of work being done in South Africa around this, kind of better rates for their insurance if they are doing certain things. If they're kind of if you can keep track of the physical activity as part of their personal health record, and it feeds back into kind of the private insurers, then that's obviously all patient led and patient choice around that. So it's not an automatic pull, but it gives the patient the option to be able to do that kind of through the one space. So I think that's another value add, and I think that would be an argument for private insurers to say, well, we want to build a plugin for something like this, because actually it may actually give us value as well later on, as well as the value that you shared around. These are the meds that have been paid for. That's actually, because part of that is what's actually been picked up We get some of that in pharmacare, but not always, especially if it's out of province stuff, which we're on the border as well. So that comes in there. So yeah, those are my initial comments. But I think it's a brilliant point that you raised, and I think there is opportunity to move into that space.
Yeah, I think it's it's interesting, and again, Pacific Blue Cross is predominantly the majority of the 1.6 million people we cover are in the province of British Columbia. We are predominantly covered through employers, and so we actually don't, when we set rates or our premiums, generally the premiums are just based on, I'll call it the industry. We don't actually, and I don't know of any insurer that is actually going down into an employer's workplace and saying we would charge you different rates to a segment of your employees who have really healthy living. Right? That's really out into the future versus those that are a much higher risk. But I personally believe that for anyone's care, you need a fulsome set of information that everybody could see and that I could see as a patient, and trying to create a care plan that is going to help me. And I don't, I traveled with my mom as she was seeing many healthcare providers, and she was always repeating her story. It would be just so nice to be able to have someone be able to review the story and actually get to the discussion part versus the historical part. And that's where I see and really find to me, the value of a personal health record. And, traveling, I would love to be able to travel with it. So anyway, but I do see value in insurers wanting to do this. I think we all have the same thing. We all want to improve the health and well-being. We know we carry a certain amount of the data that no one else might be able to feed us, that we could easily participate in.
Sorry, Pablita, did you have a question?
Oh, actually, it wasn't really a question. It was more of a pilot program. When Ray talked about South Africa, I was gonna mention, so I sit on the Caribbean Palliative Care Association board, and one of the pilot programs in the Eastern Antilles Islands is really around that, having a health record, because in the Caribbean, people move in different islands so often, believe it or not, so one of the things that they're piloting is it's really through the social prescribing type of work, which I think really resonates with what I'm hearing from Liza in terms of seeing the person as a holistic care. So they've partnered with private organizations and insurance companies to provide particular information on patients, so that the insurance companies get a bit of a break from the government, actually, in terms of incentives on like premiums. It's a whole ordeal, but they're doing it in 3 of the Anglophone islands, and believe it or not, there's about 250,000 people on this program. It's more geared to seniors. They're starting off with seniors, but they've seen a lot of advancement in terms of getting records from the private sector, from allied workers, and from the hospitals. But what's feeding it is through the social prescribing type of framework, because it's a couple of centers, key doctors, key physicians, and they're subscribing people, organizations that have signed up to this database, and that's how they're continuing the work. So it's in its 3rd year. So there's definitely opportunities, but I think for something like this, we're at least we have people in the room from different sectors that are on the same path. But I think we're going to have to be creative, because there's definitely an opportunity for sure. And I'm just mentioning the Caribbean because it is very difficult to get several Caribbean countries together to agree on a system. So the fact that they're in the 3rd year, I'm just saying that speaks loudly. So there's opportunities for sure. Yeah.
Thanks, Pablita. And sorry, Jess, just before you go, I have to apologize. When we were doing the roundtable introductions, I missed Paul Kendall. And I also note that Jane has joined us. So if you don't mind, just very, very quickly, maybe Paul, you could introduce yourself, and then Jane as well, and then we'll hand it back over to Jess to continue.
Sure. Hi, I'm Paul Kendall. I'm Networks Coordinator with RCCbc, located in Vancouver on the unceded territories of the Squamish, Musqueam, and Tsleil-Waututh peoples.
I'm sorry, Jane, you're still muted.
Okay, I'll start my little shtick again. Jane Osborne, pronoun she, her, queer senior. Coming to you from the, very gratefully so, from the unceded traditional territories of the Snuneymuxw and Staminas nations. I work on Vancouver Island from the Malahat to the tip and out to the west coast. I'm in the community sector, specifically adult guardianship, but because I work with a provincial organization, I can't overemphasize the importance of working closely with the various organizations that are responders in our legislation. So that includes health, etc. I have a keen interest in rural and remote health and the difficulties that are so multiplied by, in communities where you have to maybe take a water taxi after going down a rough logging road, if you can get there at all, or fly in. And Gordon, you invited me to this. I am a member of the BC Rural Health Network and also part of the Rural and Remote Working Group for the United Way. I don't know what else to say other than I do have a background in technology. It frustrates me to hell that, here I am, 76 years old, and frankly, it doesn't sound much better than it was when, 25 years ago when I was still working in the game. So there you go. I'm here to listen and find out more.
Thanks so much, Jane. Really appreciate it. Jess, back to you.
Sure. I've only got a couple more slides. It was interesting as I was listening, though, it was like a perfect segue to the third point on this slide. We workshop with both providers and patients in Valemount, and we wrapped around the PHR 3 sort of high-level priorities. One was that to leverage existing technologies to seamlessly share, access, and manage our patient information. Okay, sorry. And then, we all have, most of us have a piece of technology in our pockets, might as well leverage it the same way we do to access our banking information, for example. Another priority being to maintain a single patient managed record. Again, speaking to that whole, not wanting that whole portal soup concept, having to go, okay, I've got some kids interrupting me here. And lastly, and this is a key point, so that the personal health record wouldn't just be a place to access information, but it would have built-in functionality to facilitate that communication between the diverse members of the care team. So I'm going to talk a little bit about our innovation lab. Valemount was the first community of its kind to flip the switch on a minimally viable personal health record in northern BC, working in partnership with Bright Health. Bright Health is a nonprofit vendor that provides the My Health Key PHR solution. They flipped the switch in December, and I'm in a meeting. Oh, good grief. Children.
Children at home. They just got out of school.
It's like a
joys of working from home.
Joys of working, exactly. Anyhow, what's special about the innovation lab isn't just the fact that Valemount's one of the first communities doing it, is that it's how we're working in partnership, right? So the Rural Coordination Center, we're lucky to be sort of coordinating this process, but it is a process that's being done in partnership with Northern Health, Bright Health, the clinic, patients, and a group of volunteer patients in the community. And so what we're doing is we're actually getting our hands dirty now, playing the PHR, for lack of a better term, and hopefully finding a way to make it better. So from the ground up, from the community ground up, we're going to roadmap its innovations, right? So we're going to see what's working, what's not. We're going to look at what's technically possible. Where's the low-hanging fruit, the art of the possible, so to speak. Link that in with community priorities, and then over time, hopefully have that personal health record develop in a way that meets Valemount's unique needs, wants, dreams, and aspirations in that rural context. So we're not coming to the table with a out-of-the-box solution that Valemount has to use. On the contrary, in partnership with the vendor itself, we're looking at how can we do this together. And then we're emulating that same process now in Smithers and in Golden, both communities working with the same My Health Key PHR. And also we've just kickstarted an innovation lab in the Kootenay Boundary. They're working with TELUS's community health record. And they just kickstarted a virtual online clinic there as well. Again, we're vendor agnostic. We're happy to work with anyone. So talk to me in 2 years. If we could have this process kind of grow in more communities, then we can influence peripherally and role model a way to a future that has that sees integrated holistic PHRs rolling out throughout our system in BC. Now I'm finally done, so I can stop sharing and see who I'm talking to. Great, I'm back.
It's just, it is difficult to, same, I was thinking, trying to find a screen configuration where I can see everybody. Any more general questions? I mean, certainly, I guess, could I ask a couple things, Jess? Is one, is there a sense here of sort of timeline? Like, how long do you think the Valemount pilot will take to prove out some technology? And yet, I mean, I think some of the comments you heard back are, I mean, I think every one of us probably has several personal stories of saying, yeah, that out of a health authority to another health authority, or something that happened at a hospital that maybe isn't back in a health record. But yeah, I mean, time-wise, what are you sort of hoping?
Hoping is the operative word. I'm new to the healthcare sector, and I've discovered things always take longer than you want them to. And that's okay. We've had this little COVID thing happen, which was a bit of a pain. So there's a lot of pivoting priorities, and people are busy, right? People are busy, so we're kind of going at the community's pace. So we're now in discussions with Bright Health. In a perfect world, I would like to see in the next year and a half, I would like to see that minimally viable personal health record have a couple more key functionalities added to it, specifically around the care plan. Proxy access is another functionality that's we've heard is very important. That's the ability to share your record with basically your family. So if you're an adult child looking after a mother or father, for example. Forms, I know, Ray, that's one that probably speaks to you. So we haven't wished this long, but here's what this is like. So I'm going to Valemount next Monday. Here's a practical example of how this project is supporting community. The clinic is busy getting patients to register onto a PHR. It's not rocket science, but it takes time, right? Time is a hot commodity right now. So what we heard from the clinic is they needed some help, right? So we're going to go to Valemount, spend 2 days in community, hands-on at a desk, helping people register for the PHR, which is simple as having them send a link, helping them check their email, putting a bookmark in their web browser, setting a password. It seems pretty basic, right? But you know, it's not always that easy for certain people, especially seniors. We went to the Seniors Lodge. So talk to me next week. We'll have a couple hundred more people in Valemount registered, and then we're going to take it from there. So I'm not sure if that answered your question, Gordon. It's going to take longer than we want, but I think that we want to go, better to go slow than to go fast. We're going to go slow to go fast.
Exactly. Makes a lot of sense. I see where Lisa has her hand up as well.
So I think I've sort of got a sense of what you're doing or trying to accomplish in your pilot. And you know, if you are planning on building out, you know, APIs that people could gather data from different sources, whether it be health authorities or various clinics, or even a private insurer for that matter, how are you managing the privacy and the consent portion of it? So, for example, you know, if a private insurer wanted to be able to share, you know, Jane Smith's personal health information, she was part of your pilot. How do we, you know, and we were the insurer, how do we know that you've got the consent? And, you know, and what are you doing about privacy in terms of transmitting that data? Because it's almost like you've got to do a link. You've got to build an API, and every time that person's accessing their record, they're getting the most recent records from, say, our system, right? Any thoughts or where you're heading on that front?
The short answer is we aren't doing that. Those decisions would be made under a policy framework that the government would decide, probably presumably in partnership with the vendors. But I'll pass it to Bridget because I think she'll probably have a better answer than me.
I was just going to say too, the vendor, Bright Health, is managing some of that on their side. So they're the ones that help us get the patients enrolled, make sure it's the right patient, identity management, all the privacy and security in place for access. Then we also have at the provincial level a document exchange or APIs called Clinical Document Exchange, so CDX. And CDX is the provincial level security piece where information moves around securely. So anyone connecting to it would have to be vetted, would have to make sure that they reach, all the conformance that would need to be before any information is moved anywhere about anybody. Ray, you've got your hand up.
Yeah, so again, awesome question, Lisa. So yeah, so the Bright Health, so any of the personal records meet the provincial data standards anyway, the privacy requirements. Bright Health is actually linked into an EMR, so it's the same standard as would sit on an EMR. And where I think this is very interesting, and that maybe potentially where you're going, is one of the reasons that we're really pushing this quite hard is this starts actually shifting the way that we have approached privacy and consent, particularly in our province, because we've taken pretty much a top-down, almost a paternalistic approach to this, which basically says that someone in the government is going to decide how we keep you, kind of what you share and what you don't share. What this starts opening up the door with the open standards and the APIs for consent to be managed by the patient. The majority of people should be able to give consent and say, I'm happy to share this, or I don't. It's informed consent, obviously, and that actually should be able to be put as metadata on each discrete piece of data within a personal health record. So a person can say, I'm happy for this piece to be shared with any doctor or nurse who's looking after me. I'm happy for my data to be used kind of in an aggregated, anonymized way for health systems planning or not. I'm happy for my data to be used for research or not. Or actually, I want to send this piece of data to this person. So that is actually a part of the end game here, is actually completely flipping the current approach, because the privacy, one of the reasons we're in such a dog's breakfast in our province at the moment is privacy. And the fact that it's kind of been over-applied. Certainly, I know the bulk of my patients expect when they go to the specialist in Kamloops that the specialist can see everything that I see, and they're actually shocked when that doesn't happen. So I think there's the theory and the reality, and so there is an opportunity, I think, with this, if you do really have a system that sees health data, but the center of health data being the patient, not the doctor's office, not the hospital, not the diagnostic center. And I love the way that you've introduced this idea of not the private entities who are involved in health and health provision in any way, shape, or form. But as a patient, it actually starts flipping the whole model around how we deal with privacy and consent. And then obviously there is the need for a safety net. When people are unable to give consent for whatever reason, then there needs to be kind of a safety net around that.
So Ray, just to follow through on that, if the program is sort of taking a paternalistic approach in terms of government sort of structuring the protocols or the framework in terms of consent and how information can be shared, and I like the idea of every. And I always try to think. My mind always goes to the sort of the end result. So, if again my fictitious person Jane Smith says yes, I'm good with. I sign consent wherever that consent is, and all my information can be aggregated. So in one place, my personal health app, so I could show it and share it with whoever I want to. I just think of trying to involve the private sector earlier than later, because the private sector holds so much health data about the person. And I'm not, I realize we're a little bit sort of after the fact, after emergency, but it really, I think, paints a different picture of, we process, I know we're a little tiny compared to what the province is doing, but we process, over 25 million claims a year about people that are pretty impactful and meaningful. I would have to believe, to their caregivers or to their healthcare providers or their healthcare network that is going to look after them, that could provide a different insight into
100%.
treatment care recommendations.
Yeah, 100% agree. And what I'm hoping I'm hearing is maybe an invitation or an interest to kind of engage for the personal health record group to kind of engage with Pacific Blue Cross. And
yeah,
I think we'd be super interested in doing that.
Great.
Happy.
I want to go around because there's several people that we haven't heard from, but I guess the other thing I would just like to make a bit of point that I think a lot of us in rural BC, I guess the other thing I'm sure you are aware of, Jess, I know Ray would be, is, most of us are deathly afraid that our family GP, if we're lucky enough to have one, and I am, who's about my age, so he's going to retire pretty soon. And my greatest fear, of course, is I can't get a replacement. And I mean, hopefully now, I'm hoping, Jess, and maybe you or Bridget or Ray could tell me, is, now, like whenever 2006, when I moved down from being in Prince George for 10 years, everything was a paper record. So they had to request somebody go down the basement, find it. I doubt it was ever digitized and put in. But now when my guy leaves or retires, I'm hoping most of that's digital. Will somebody actually have access to it? And I think part of the reason I was asking about the timing is, as you say, I mean, I think there's so many elements that could be built into this. On the other hand, I suspect some stuff is more critical, maybe from a time-wise, as you say, about how do we, if we know there's going to be a pretty significant changeover in the system, how do we make sure that just even some of the existing digital records are kept track of somehow, don't disappear.
Yeah, I would keep a copy of your paper records just to be safe. No, I don't have. There's no crystal ball there.
Yeah, for certainly for public health data, there are requirements for keeping records, paper or digital, for a period of time, and it varies on your age and all of that kind of stuff. But most paper records now are, like, if somebody retires, their office records go to a storage company usually. And that storage company, those storage company nowadays are digitizing them, not in a particularly useful way. They're scanning them, so it's not very easy to actually integrate that in. And so it's a great point, Gord. I'm going to say the first step on the journey is actually, let's get everything from now forward, then get as far back as we can. And I think with EMRs, we will be able to go back pretty easily because a lot of the data is kind of discrete. But that's really, in British Columbia, only been kind of mainstream for, maybe, Bridget, you were involved in the initial, 10 years, a little bit more than 10 years, where most of the province has been on some kind of EMR.
Yeah, probably over 98% now of physicians in British Columbia are using electronic medical record. There's also, right now, we have several provincial registries where your data is being stored. There's data inside the EMR, like Ray has, your care plan and information that he has in there. There's also data at the provincial level. It's not a lot, it's a start. So it's one of the portal soups. So if you haven't done it, look up the Provincial Health Gateway and you'll get some of your data there. So I'm in Smithers. I had a lab done at our local hospital. It showed up in my Provincial Gateway the next day. So that data is already flowing. So the lab's there, some medications there, not your full record isn't there, your GP record isn't there, but it is a start. So if you haven't done that yet, please have a look there. If you need any help, reach out to me. I can help you with that.
Following through on that thought, and I similar to Gord, I too have a family doctor about my same age, expect to retire, and I probably don't expect to easily find a new one either. I know he's been using an EMR, an electronic medical platform, probably for 5 years. I'm making the assumption when he retires, all the notes and all of the information that is being fed into him goes with him. It's not going to reside anywhere else. It's his license to use the product. So that's where I'm trying to understand. And I realize that there's small feeds up and I've looked at my Health Gateway to look at my lab results of the drugs that are being processed, or which doctors I've seen. But what's really missing from all of that is what are the, to me, which is the most important part, is what was the key elements of that visit about? What was the outcome of that visit? And that to me is, and even, and I'll say this from a private insurer point of view, we pay for encounters with, lots of allied healthcare professionals and dentists. We can give you some detail on, if it's all codified, but a lot of it is, we know you had a chiropractor treatment. We don't know what part of the body, is it what we've got to think about, I'll say codifying our treatment, that we're all using standards. We've got ICD-9, we've got things like that, but you need a lot more than just those type of models.
And just to clarify, Lisa, the health data in a family physician doesn't actually, the data does not belong to the physician, it belongs to you, legally, and they're required to store it and have it accessible to you. I just
have to hope to get it from him before he decides to retire.
But once he's retired, he's required to actually set up a process that you can get it in 2 years or 3 years. I think it's 7 years at the moment. So there is a way. And that's required by the college for them to be able to do it. So when he goes, your access to your record that he holds shouldn't go. But you're right, it becomes much more difficult.
And just to clarify, Ray, that's analog, right?
Well, it depends. So like Bridget said, if it's 7 years of data and they've been on an EMR for 7 years, it'll be digital. But if
scans,
it's maybe no, it'll be in the format of the EMR, whatever the EMR is. It'll be kind of stored in however they're going to store that. But if it was paper, then it's just going to be a bunch of scanned pages.
I definitely see an opportunity with what you're saying, Ray. And I see an opportunity, and I don't know what body that falls within, but to be able to educate the public of how do you get access to that data? Like if my and I'm going to use the analogy of my doctor wins a lottery and just disappears into a nice tropical place to go live in. How do I get access to his EMR when he's not? I don't even know where he is. Can't access him. How does the public member do that? Is there an education that could be considered to help educate public on what are the right steps to take?
It could be a component of the PHR as well as, what to do if some of my records are available, like a resource inside a PHR to educate that one. I think we only get a few minutes left. I noticed Mark's been his hand up for quite a while.
Yeah, I just wanted to jump in and thank you, Bridget and Jeff. Good presentation. I just want to encourage you to kind of think about the patient journey mapping that you did at the beginning was focused in on a particular patient journey. And Pavlita and I could tell you about, for example, end of life journey that is 80-90% of the core, outside of the core health construct, or the usual kind of thinking about pharmacies and so on. So just to encourage you to kind of keep going down that path of thinking about different and high priority journeys, because Jeff, you had the graphic of saying, hey, but a big long list of priorities for additional functions. So each journey discussion will, I think, dictate kind of new ideas and different ways, and also the idea of the bigness of the journey. So pregnancy journeys are pretty nice and compact in some ways, but frailty journeys or older folks, their journey is quite different. They're touching the doc maybe frequently or maybe infrequently, but their social supports is key to their health and their minimizing their frailty. So the whole idea of thinking about those journeys a half a step outside of the healthcare system will be added value. But yet you need your process, and I just kind of encourage you to kind of maybe have some other folks around that table. I didn't want to jump and suggest, but Pavlita could probably tell you a whole bunch of those pieces of the puzzle, but it's really, really important. The second piece, which touches on those, and the pregnancy journey or the frailty journey or the journey associated with end of life, where patient portals, I think, will be really something that people will just really hang on to and go to, is where they start to add value beyond the efficiency equation. So the efficiency equation is, hey, geez, I don't want to tell my story 15 times, or I want to have the most current information in front of my next provider. Those are all very legitimate, but I would say those don't actually make the case for added value. So if I go to the portal, for example, and it's actually helping me navigate the system more specifically, right? So the long-term care, making a decision about long-term care, making a decision about home health, making a decision about pregnancy and my options and so on. So all of a sudden we're into this bigger, way bigger space of the value add of information that will make a difference the moment they look at it, right? And so there's a lot of people that have long-term chronic conditions, and there's just a mishmash. And so the value out of a portal is it's credible, it's independent, it's professional, et cetera, et cetera. So I'm not going to Apple or Google or Amazon to ask what my approach might be to my diabetes. I'm going to my doctor, or the proxy to that is the portal, you know, with credible information, with credible insights that's customized or personalized to my situation. And we're learning that in the pregnancy journeys, for example. There's some interesting stories about facilitating pregnancy with digital apps, and how that access, because of course that age group is very motivated to get their care as much as possible digitally. That's where the value add is potentially very, very powerful. And that's where it could be personalized with AI, for example, where you can say the pregnancy of a 17-year-old in a small community with no social supports is a different pregnancy journey, or predictably a different pregnancy journey, than the 32-year-old who has 17 relatives that live within 3 blocks and is their 3rd child, right? Different journeys, different experiences, different needs, right? So that's the next wave of value add that I think you need to somewhere, you know, start to explore, because there will be some areas, depending which journeys you start to pick on, that or focusing on, that can really really draw people into the portal space.
Right.
Because as you guys know, the existing portal soup, people go once, maybe twice, and that's it, Deadsville in some of those portals. That's the experience so far, you know, 10 or 15 years of portal experience in Canadian healthcare. And that's pragmatic, right? You look at your lab results and you say, okay, I'm in the normal range, thank you very much. And I might go back 6 months from now, my next lab. But if I'm a diabetic, I might go much more frequently, and I want very specific information that feeds on the basis of those results. So anyway, I'll stop there. Just it's an exciting project, and I just encourage you to kind of think about some of those other journeys.
Yeah, great points. Can I just ask, I mean, if people don't mind, maybe we could go another 10 minutes. I know some people had to leave already, but I did want to just see if Mike or Alex or Jane had anything that they would like to sort of add from this. Maybe I'll start with you, Mike. This is a lot of stuff all at once, but.
Yes, a lot of stuff at once, and I appreciate the opportunity to gain a better understanding of this whole process. Have heard of you know, the process that they're embarking on, and I think it has a value add. The disconnect that we hear in rural communities is huge, right? So I'm not lucky enough to have a family physician, so it's a crapshoot when you go to see the doctor's office, right? Who am I getting? How much do they know? And yeah, I see a total value add. Don't have anything more than that to add to it. I do like the concept of taking into consideration the journeys, because not only is it, you know, to that point of the journey is different, even though a pregnancy should be a standardized process, it isn't. It's individualized, right? No different than someone having heart surgery. And you know, in my case, I had heart surgery, and it was basically fixing a valve, and away we go. No complications, basically got a new lease on life, and away we go. So it's real simple, it's real easy. Whereas my friend next door may have a different approach to it because of having to have a lifestyle change, that sort of thing. And so when, you know, in my community here, I see somebody different today that I didn't see 2 months ago. Yeah, I don't want to go through that 20 minutes worth of, oh no, wait, I only got 15 minutes to say that 20-minute story, and I'm hoping for some help, right? So I applaud this. I think this is amazing. Enjoy being a part of this and hope to be able to continue being a part of this discussion down the road, and hoping to be able to provide maybe a little bit more value add as I know the journey that this is on.
Exactly. No, thanks, Mike. I really appreciate that. Alex, any thoughts on this?
No, I too just want to say thank you for including us, including the BC Chamber. I think the value is very clear and self-evident. I really did appreciate, Jess. I think I got it when you mentioned that the record is like the patient owns the record and they can choose who to share it with, as opposed to the doctor, which made a lot of sense to me. When it comes to control over that information, I thought that was helpful. Just as a individual, that was very attractive and helpful way to think about this. Yeah.
Oh, I appreciate it. Thanks very much. Jane?
I'm just kind of, so new. Gordon, you invited me some time ago to come to one of these meetings, and I just want to say I'm really, really happy I came. I hear the themes in many, many different places around BC. Funnily enough, I was in Valemont just a few months ago for quite a while. Visiting different areas, I hear the same themes. So, and I realize how privileged I am sitting here in an urban adjacent community of Nanaimo, going to a clinic that is really quite well connected in terms of the professionals that are connected to that, including allied professionals. So I'm one of those fortunate people, but I just also know not very far from my doorstep, that is not the case, and that is not the story. And people are really worried and scared. So it's great that this work is happening. So good to see you all on screen. I'm glad I got here. Thanks for inviting me, Gordon. You've now got me hooked. Oh God, no.
That's what we were hoping.
Between Paul Adams and you, I'm doomed,
Exactly.
Won't have any time for work.
Yeah, that's right.
My work.
Really appreciate it, Jane. And just Alex, Jane, and Mike, all of you missed our first meeting before the summer. I might ask Sarah again, if you don't mind, Sarah, you could send out the link again. We actually recorded Ray Markham, and he did a bit of a spiel about what the RCCbc is hoping to get from the linked sectors work. One of those diagrams that Jess put up, you will have seen that there's this pentagram plus, because there's actually 6 nodes. There was a rural citizens group, well, still is. I think maybe even Jane was part of it. Certainly the co-chair of that was the BC Rural Health Network group with the Patient Safety Council. And then the linked sectors, which is meant to be more nonprofits, employer groups. And really, in a nutshell, the RCCbc, Paul can correct me if I'm saying this wrong, but is just really trying to get a perspective of some primarily rural folks or people that work with organizations in rural communities to just get a sense of what the issues are. So we tend to touch on a whole bunch of issues. And I apologize, a lot of times an hour is nowhere near long enough to really engage in an in-depth discussion. But what we try to do is try to limit an hour so that we're not using up too much people's times. And then like today, I think, what we've seen now is because of some of Lisa's comments is an opportunity now for Jess and Lisa and others to work on something in more depth. And I think we'll find that on a lot of things. One of the things I wouldn't mind just quickly asking sort of Naomi and Mike, as for, fellow rural residents, because I spent 10 years up north as well. And Jane mentioned the thing that Ray mentioned to me that I had no idea about these records are supposed to be available. Do you guys see any value? I thought maybe I should reach out to Paul. Sarah and I could work with Paul. I think a webinar for rural folks to understand how they can access that, because we got a lot of doctors retiring, specifically in rural BC. It's damn near impossible, it seems, to be able to recruit people into rural locations. And I think that rural people would really appreciate knowing that apparently those records exist somewhere. And maybe people like Bridget could help us explain to people how the hell you're supposed to do it. Because as Lisa says, my concern is, I think most of the time, the doctor, as far as I'm concerned, they're gone. Like, I'm never going to be able to contact them again. So I need to know where the hell that stuff is.
It's which system they're on. So that's the format you get, and then how they're holding it and what they're held to. And if they can't, they give it to the doctors of BC. And there's actually a company there that holds them. And I have a link to that. So I can help that piece.
And
I think that would be a great idea, because
Yeah.
I have stuff and I don't know how to access it. Like,
yeah.
First call, just call your doctor's office and ask them. That's the
sure.
advice I can give you the
And-
first, because then they'll tell you what they did. Right?
Yeah.
They'll-
Exactly. It's a lot of the things up here is a time thing too, because you got to make an appointment. For example, at my physiotherapist, and she was like, "Oh, we need all the stuff that was done at Vancouver in the coastal health thing," and then to make the request to get it to that, it just takes forever. And I think that's a lot of the frustration, because many of these times time is of the essence. This information needs to be gotten like now. So yeah.
And I think the other concern I would have, Bridge, is for many of us in rural BC, well, you know this, you live in rural BC, is that, I mean, it's locums for the last 3 years, we might not have it, as Mike said, right? So, and I don't know how much of that stuff locums are entering in.
It's
And
an
again,
average 3 weeks to get a doctor's appointment in the north, if you're lucky. Yeah.
So all locums work under the clinic itself. So the information would be in whoever they're locuming for.
Okay.
So if Ray had a locum in, that person is charting in Ray under their own name, but in Ray's system. So Ray would have access to that. But yeah, happy to come back and help you with this. Love this stuff. Just never passionate about this work.
Exactly. Well, great. Well, thanks. Any final comments or anything from anybody? Thanks so much, Jess and Bridget. I really appreciate it. It's a very complex topic to try to cover very, very quickly. I mean, I was just amazed. I didn't know, my kids told me that I didn't even know we could get our immunization records, right, of everything on public health. But again, little things you don't think of. My son's girlfriend was here, and when she was looking at it, she said, well, all this stuff's there from public health, but nothing's there from a private immunization clinic I had to go to for travel stuff. So, things you just don't think of, right, till you're sitting with somebody. So, Paul, any sort of last thoughts or words from RCCbc as well, or?
Nothing on behalf of RCCbc. I think Jess and Bridget did a great job of this. So
yeah,
thank you.
So I put my email in the chat.
Perfect.
So I welcome any questions. Please connect with me. I'm hoping this doesn't end here. I'm hoping we can find a way to connect again, continue the conversation.
Exactly. Well, great. And just for those that are, just as Sarah's going to we're going to send out an email too to see if we can organize a meeting for late October or the first week in November. Again, we might start with a topic, something like, I think, some of the suggestions we got were around, private insurance providers like Lisa, some of the issues around that. So we might use that as the first topic. And then again, any thoughts that people have of a specific topic they might like to talk about in future meetings, please just send me an email and we'll organize it. Other than that, thanks everybody for your time. I really, really appreciate it, and hope everybody has a good evening.
Thank
Good
you.
night, everybody.
Bye, everyone. Thanks.